Hello and welcome everyone. I'm Melanie Dizon. I'm the Director of Education at the Davis Phinney Foundation, and today I am happy to have Dr. Janis Miyasaki with us to talk about pain and Parkinson's. Hi, Dr. Miyasaki. Thank you so much for joining us.
Thank you.
Now a little bit more about Dr. Miyasaki. She is the director of the Parkinson and Movement Disorder Program at the University of Alberta. Her area of interest is in novel patient care delivery, including development of the first neurologist-led palliative care program in the world, positive psychology in Parkinson's, and communication skills. She's been a speaker for us at the Victory Summit event, most recently in Seattle at the end of 2018, and her talks always get rave reviews. So we're really excited to have her here today. Okay, so I'd love to get started by talking broadly about pain. According to some estimates, somewhere around 60 to 80% of people living with Parkinson's report pain. Is that percentage accurate to what you see in your office, and is pain a common concern that you hear from your patients?
Well, pain, first of all, is a very personal experience. So what one person calls pain, another person might just call an ache or a twinge, or it feels like a pulled muscle, and they don't really pay much attention to it, nor does it inhibit their abilities. So that estimate seems a little high for most people who have dealt with Parkinson's for a long time. And it probably reflects the most generous, broadest view of what pain is. And so I think we have to keep in mind that some people are very stoic. They'll never complain about pain. Other people, if they get a cut on their finger, it's like a life and death situation, and they come with a big bandage around their finger. So I would take that with a grain of salt.
Okay, so what are the different types of pain experienced by people with Parkinson's?
So people with Parkinson's can experience similar types of pain to the general population. Probably the most common, once you get over 40, is musculoskeletal pain. So those aches and pains from misadventures in your youth, when you went skydiving and maybe you shouldn't have, when you tried to run the Boston Marathon and you shouldn't have. So those things tend to become reactivated as we get older and emphasized. And additionally, Parkinson's can exacerbate those musculoskeletal problems or make those musculoskeletal problems worse. Because when you have Parkinson's, the tendency is not to move as much. And then, as many people who have arthritis know, movement actually helps, even rheumatoid arthritis. The next type of pain is something called neuropathic pain. And that's a fancy way of saying we believe the pain is starting in your brain. Not that it's in your head, but really that because of the wiring in your brain, it's perceiving things that shouldn't be painful as uncomfortable, or as creepy and crawly, or tingly. And this is also seen in Parkinson's disease. And then we think of pain that is related to treatment. So people often say, as the pills wear off, or when they start to work, I know because my hand starts to take this posture and cramps. It lasts for 10 minutes to 30 minutes, and then I know I'm going to be on.
Okay, so the musculoskeletal pain, a lot of times people, we highly emphasize exercise. And so people will come to us and say, but it hurts. And so what has been your experience in terms of the time that it takes for, let's say somebody is experiencing that type of pain, that they do start to exercise and move more? How do they know? There's those people sometimes that haven't exercised a lot, right? And then we tell them, oh, all of a sudden now you better do this every single day. So what is that sort of pain pathway? How long does it take for those to kind of kick in to start feeling better?
That is a good question. Uh, because you're right, we do tell people exercise, and many people have been sedentary for years, if not decades. And the commonest trait among people with Parkinson's is that they're very diligent. If you tell them to do something, many of them are going, okay, I've got to exercise. I'm going to exercise 2 hours every day. And as one of my patients said, for me, yoga becomes a competitive sport. And I think the first thing to know is, just like any athlete starting out, you never start trying to run the marathon. You start gradually. You start walking, and then you increase the pace. And a good rule of thumb that I use for my patients is that they should do a moderate degree of exercise, 35 minutes, 5 times a week. And a moderate degree of exercise is being slightly short of breath while trying to keep up a conversation and do the exercise. So it doesn't mean you should be gasping for air. It means that you're slightly short of breath. And as your endurance, both your cardiac and your lung endurance improves and capacity improves, and your joints, most importantly, accommodate to this increased exercise, you will find that it takes more and more effort to get to that slightly short of breath. And that's a nice natural way to tell how intense your exercise should be. For some patients, telling them to take their medications before they exercise can be helpful. So if they take their medications at 8 to try and exercise at 9 or 10 when the medications are going to be working, or for people who have a lot of musculoskeletal pain, to take some Tylenol or acetaminophen or ibuprofen about an hour prior to their exercise to reduce some of the discomfort. And then for most athletes, if you feel too much pain, that's a sign that you're actually doing something wrong. Either the form is wrong or you're doing it too intensely. And so I would not want people to discount pain as a sign that maybe something's not right. And finally, we have to recognize that because people have been sedentary for a long time, and we are now seeing an increased link between diabetes and Parkinson's disease, that perhaps the pain is due to something else. Maybe it's not related to Parkinson's or osteoarthritis. Maybe it's related to having a herniated disc, or maybe it's related to another medical issue. And so people should keep that in mind and have a good connection with their family doctor, not so that the family doctor is always saying, oh, it's your Parkinson's, but keeping an open mind, because people with Parkinson's can get other illnesses. I always have to remind my patients of that. You're just as likely as everyone else to get something else.
Right. Which is why it's also important to, keep a good relationship with just your family doctor who's going to be on track and keeping track of all the different things that are coming up for you and being able to refer you to somebody else. So here's a question. Does there tend to be pain, for pain complaints in people with Parkinson's in movement symptoms more than those found in people with Parkinson's that don't have motor symptoms as their dominant issue, like people that are more non-motor symptom dominant?
Could you repeat that question?
Sure. Do people complain of pain more who have motor symptoms as their dominant feature, or those who have non-motor symptoms as their dominant feature, or does it seem to just be everybody has general more pain?
So non-motor symptoms, pain would be a non-motor symptom.
Right.
And in general, non-motor symptoms increase with the duration of the illness. So we often, in our clinic, we do the non-motor symptoms questionnaire at every visit. And we see that at the beginning of the illness, at least when they first come to us, almost everything is a no. And then as the illness progresses, we see more and more yeses. And in fact, after 5 years, if we don't see a lot of yeses, we either wonder if that patient will never complain of anything or if the diagnosis is correct.
Mm. Interesting. You also talked about the relationship with Parkinson's and diabetes. Can you speak a little bit more about that, or what's the situation right now?
Yeah, so we are noticing an increased association between diabetes and Parkinson's. And as many people may be aware, more recent research in diabetes seems to indicate that a lot has to do with inflammation in your body, because when you have fat, it's not, everyone thinks of fat as something that just sits there. But in fact, fat is an organ. Fat is living. And when we get too much visceral fat, that is increasing inflammation. And there has been a long-standing theory that Parkinson's is related to inflammation. And this is why the investigators at Washington University had attempted to study using medications to reduce inflammation to see if that would reduce the symptoms or stop the progression of Parkinson's. And unfortunately, that study of nilotinib was negative.
Okay, interesting. So that's something that everyone's going to keep an eye out for. How does brain, this is a question from a viewer, how does brain originated pain differ from overdoing exercise, and how can you tell the difference?
So neuropathic pain in general tends to be fairly consistent throughout the day, whereas overdoing exercise, it's after you've done too much exercise. So I restarted running recently and I got plantar fasciitis. Ironically, 2 weeks after my colleague got it, and I said, whoa, that's unfortunate for you. And then 2 weeks later, I got it. So karma is kind of painful. When you know that you've increased your activity and then you start to feel knee pain, you think, oh, that's probably because I increased my activity. And I can't tell you how helpful a physiotherapist can be in dealing with that. We often look to the movement disorder neurologist. When I first started, the movement disorder neurologist was everything to the patient. But I think we realize now that so many team members have an important role to play. A physiotherapist, when I had a tear in my anterior cruciate ligament, he diagnosed it. My family doctor said my knee was fine. My physiotherapist immediately after just doing a few maneuvers said, you have a tear of your ACL and here's what we're going to do. So if you have pain that's associated with your activity or worse after your activity, I would encourage people, if you can afford it or if you have access to it, to access a physiotherapist, because their ability to examine the musculoskeletal system is just superb. And then if you have neuropathic pain, it does tend to be more consistent. And as opposed to that aching you get when you are doing an activity, the neuropathic pain is just this creepy, crawly, uncomfortable sensation. And it is spontaneous. It's regardless of what activity you are doing, it tends to be present. Although when people are quiet and resting, it tends to be more noticeable, probably because they're less distracted.
That makes sense. Somebody asked a question about Tylenol. They had heard that people with Parkinson's should not take Tylenol. They should only take Aleve.
Well, I have never heard that recommendation. Aleve is a non-steroidal anti-inflammatory, and so we have to be careful about taking it because it can be hard on the stomach and it can cause peptic ulcer disease and actual bleeding from the stomach. So taking Aleve can be fine in small amounts, but acetaminophen is actually a mainstay and the first step of the pain ladder that we try both physical methods like applying cold, applying heat, but I would just caution with heat. If a person is immobile, letting them lie or sit on a heating pad unattended is not good because they may not be able to move off the heating pad. But if someone is able to control it themselves, using a heating pad can be helpful. And then using acetaminophen or ibuprofen is recommended as the first step on the ladder. There is nothing specific about Parkinson's that would make acetaminophen contraindicated.
Right. So it would be something that you might have your own issue with it, but in general,
Yes.
It's not a problem. Where does dystonia fit into this pain, these three different types of pain, and what are some of the ways that people can manage that?
So dystonic pain is that pain that I first described. So for the person who asked, it tends to be either the hand or the foot, and it's in a cramped position, typically first thing in the morning or when the medications wear off. So the general management is to increase the dose of medication and to help it last longer. However, some people who have escalated their dose a lot because they are intolerant of the off periods, usually because of anxiety, those patients can get very bad dystonia. And in those patients, decreasing the dose can be very helpful.
Okay, so that's
the other, oh, sorry.
Oh, no, go ahead.
If dystonia gets to be either prolonged, severe, and disabling, and someone still responds very well to levodopa, considering functional surgery, so deep brain stimulation or a lesion, or considering duopa can be helpful.
Great, thank you. What about, is pain often a side effect from medications, or does that not tend to be an issue, or is it not something that you can really pull apart and say, oh, this is a side effect?
Generally, if the pain is on the side that is most affected by the Parkinson's, and it tends to occur in the same schedule as the medications, then you can say that it's related to the Parkinson's and its treatment. The challenge is that, of course, if we stop the levodopa, you would not have any painful dystonia, but you would also not be on ever. So it is one of these issues that it is the progression of the illness, the inability of the brain to handle the levodopa as it did when you first started taking the medication, so that it was smooth all the way through. As time goes by, the brain becomes less able to handle levodopa smoothly, and then you get these hills and valleys of responses, as well as the painful dystonia, and for some people, disabling dyskinesias, which can also be very painful, particularly if they're violent or involve the neck. People can get a lot of pain.
Okay. Somebody was saying that they experience very tightening of muscles, cramping at night. Is that a specific thing to Parkinson's? Is that, I think people a lot of times experience restless leg and those kinds of things. And she said that, he said that he often applies lidocaine patches to it. It usually resolves after 30 to 40 minutes, but is this something that is so common that it probably is related to Parkinson's, or is this something maybe totally unrelated and something that they should maybe see a sleep doctor or something like that?
Yeah, the only way to tell is for the patient to speak to their neurologist or their family doctor, whoever is writing the prescription for the levodopa, and to see if a dose taken in the middle of the night can help relieve that symptom. So many of my patients do complain either of tremor emerging in the middle of the night that is very bothersome, or that kind of cramping and pain in the middle of the night. or stiffness that is very difficult and uncomfortable. And I often tell people to take another dose of levodopa and put it at their bedside. Take it when they wake up to go to the washroom and see if that will help last through the night. Because when you think about it, most people sleep for a very long period of time, and that's the longest period of time that our patients go without any medication.
Great. Somebody asked if there's any link between Parkinson's and pinched nerves.
No, there is no link between Parkinson's and what is commonly known as pinched nerve is herniated disc that then actually it causes pain because it herniates in a way, the disc between your vertebrae comes out and it actually presses on the nerves as they exit the spinal cord or the spinal column. And really the only association would be Parkinson's tends to be higher risk when you're older, and people tend to get herniated discs in their lower back as they get older as well.
Okay, great. So how do you see pain impacting the mental health or mental well-being of your patients?
Well, there are two answers to that question. One is the people who are already anxious and depressed tend to rate their pain much more highly than someone who is not anxious and depressed. So this is one factor. And then the other is that pain that is unrelenting is, of course, a cause of depression and anxiety for patients. Again, I think that treating, if someone has pre-existing depression, it is important to treat that. And I know people are reluctant to take medications for mental health, saying, you know, because we all grew up in that era, just have a stiff upper lip, pull yourself up by your bootstraps, everything is going to be fine. And that might work for many people. But for people with Parkinson's, I would like people to remember that depression and anxiety are actually associated with real neurochemical changes in your brain. And so to treat that is really like taking a vitamin. And if treating the depression and anxiety is not helpful, looking for the actual cause of the pain is important. And then applying the correct treatment for that type of pain is the next step.
Great. Let's see, somebody said that they use magnesium. They started using magnesium for their pain, especially for leg cramps, and it's worked for them. And I think for those kinds of things, it's great. You know, talk to your doctor, obviously, talk to anybody that is prescribing you medicine and say, here's, you know, I'd like to give this a try. Like, what do you think that's okay? And have them talk to you about it. I don't have Parkinson's, but I have just tremendous leg cramps every night. And I've tried every possible thing that there is. And I think for some people, it's just magnesium might do the trick. Magnesium might be the greatest thing. Pickle juice might work for other people. So I think it's really great to experiment, but just make sure that you're talking to your doctor about whatever you're planning on trying. And then talking about pain and sort of different treatments, we will get into more of specifically about treatments, but people are saying, you know, they're using CBD. What has been your experience in your practice of working with patients with CBD oil?
CBD has definitely exploded in the last few years, particularly in my country, which has legalized it. So it doesn't have to be medicinal. You can just go to your local shop and get whatever you want. And when we look at rigorous studies of pain, in fact, CBD is less effective than tricyclic antidepressants and might be slightly more effective than acetaminophen or ibuprofen, and is less effective than antidepressants such as duloxetine. So I think we have to take it with a grain of salt. A lot of people are attracted to it because they view it as natural. However, aspirin is derived from wintergreen. So there are a lot of things that we use in a medicinal way that is produced by a pharmacy that actually started life as a natural compound. So I would like people to just realize as well that CBD can be associated with changes in mood, with hyperemesis syndrome, which can be very severe and last for months after the CBD is stopped. That it can also be associated with lack of clarity of thinking and decreased motivation. And people with Parkinson's already tend to have more apathy than people without Parkinson's disease. And I think most spouses out there would say the one thing that just drives them batty is, trying to get their loved one to go to an exercise class, because they hear this all the time now, how important exercise is and socializing is. And if we are increasing apathy for our patients, then really is that the right balance? For some people, maybe it might be. For other people, it definitely is not. And so we have to keep that in mind. The other thing to keep in mind is that CBD products vary in their purity. So when they took samples from stores around, I think it was actually in Colorado. They took samples from stores around Colorado. They found that almost all samples that were said to be pure CBD has some THC in it. And THC is the compound that we believe causes the psychiatric effects of cannabinoids.
Great. So let's talk about, we talked about some of the other treatments, but what are some pharmacological specific treatments? People want to know about DBS. How does DBS actually help with pain? And then some of the non-pharmacological treatments that you talk with your patients about. And then where does neuro palliative care fit in with this kind of treatment?
So in terms of pain treatment, the principles are to start with what is called the pain ladder. So you always start with the least intensive, least side effect giving treatment. And those are the physical methods that I discussed, using cold or heat, and also stretching and flexibility. So helping people, particularly those who are less mobile, tend to be very stiff and rigid. And if you move them around, they will complain bitterly. I used to do that for my mother who had Lewy body dementia. And I used to do range of motion, and she would literally scream, "You're killing me." And then afterwards she would say, "Oh, wow, I feel better." And every day we went through this same cycle. She never seemed to recall that she felt better afterwards. And so leaving the person to do the range of motion exercises or flexibility themselves is often not successful in late stages, because their perception is when you say raise your arms and they go like this, they say, "Yep, they're up." But then when you actually stretch them out, they can get further and they're, "Oh, that's higher." So they don't actually perceive the amount of effort or the range of motion that they truly have.
Quick question about your mom. So how long, when she said, "Oh, I feel better," how long did that last? Like through a couple hours throughout the day, or?
It would last a couple of hours through the day. I have to say in the last week of life, because her care got so burdensome, I just stopped doing it. And I know she had more pain, but I just couldn't add another. I was working full time as a neurologist, this was just 6 years ago, I was working full time and coming home and doing it. I just couldn't, I didn't have the energy to do it. So I have a lot of empathy for the care partners and caregivers out there. We pile on all these things so that it's like, it seems like it's pages and pages of instructions of things to do. It's so hard to do. I understand that very much.
Thank you. Okay, so we do the hot, the cold, the stretching, the least sort of invasive methods first.
And then the acetaminophen and the ibuprofen. Then you get to stronger non-steroidal anti-inflammatories like the naproxen or Aleve that was mentioned. And then we move to antidepressants or medications that might have antidepressant activities like tramadol, Tramastat, duloxetine, and tricyclic antidepressants, which is kind of difficult to use in Parkinson's because it might cause confusion and might cause too much sedation. But those are very effective medications for pain in general. Then we move on to anti-epileptic medications that have been found to be effective for the treatment of pain. And this consists of gabapentin and pregabalin. The reason why this is considered a higher level than the antidepressants is because they can cause sedation, and at doses high enough to relieve pain, might also cause unsteadiness and increase the risk of falls for our patients. And then we get to opioids at the top of the level. I would say that if your pain has not been relieved by all these subsequent steps, that if your physician recommends opioids, to try the smallest dose possible. And some of my patients have had very striking response at doses that our palliative care colleagues really would not consider effective. And they're frequently surprised at what a small dose can do for our patients. And this can make a tremendous impact on your quality of life. Once you have good control of your pain, please don't stop your medications. This is very common that someone will say, oh, I feel good. And why am I taking this pill? They'll stop it. And then a week later, they'll call and say, and screaming, I'm in pain. And the whole problem was they stopped their pain medication.
Right. For the opioids, is it something that then you kind of think, well, I'm probably going to be on this for the duration of my Parkinson's because, you know, we found it and it's working? Is it something where you said this lower dose that it's pretty surprising? Can they stay on a low dose for a long time?
The surprising thing with people with Parkinson's is they manage on a very small dose. So when oxycodone could be cut into portions, I took the smallest dose, had the patient cut it into quarters. They took 1 quarter twice a day, and they had a remarkable benefit from, I have so much pain, I want to throw myself off the balcony, to no pain.
Wow.
And I think the striking thing about that was my palliative care colleague who was seeing the patient at the same time thought, that's never going to work. And then when it worked, he was like, oh my God, I'm so surprised. And so I think that this speaks to the pain in Parkinson's might be different. Also, the people tend to be quite a bit older. So the patients that he is often treating for palliative care specialists are often cancer patients. Now they are branching out to congestive heart failure and kidney disease patients, but many of them are still unfamiliar with neurodegenerative illnesses. And so even a palliative care doctor may prescribe too high a dose because it's based on their experience with cancer patients. So starting at the tiniest dose and then gradually increasing can be effective.
So you developed the first neurologist-led palliative care program in the world. Can you talk to us a little bit about what did that look like? And for somebody with Parkinson's, maybe they've been newly diagnosed or have had a few years, like what would something like that look like for them?
So in general, I would say that most patients who require neuropalliative care are in the later stages of illness, mainly because of lack of person power in palliative care. There are very few palliative care physicians in the world, and there are
How would
very
you,
few.
sorry, how would you characterize for the audience, how would you characterize the later stages? What are some things that are sort of indicative of that phase?
So I would call the later stages someone who is requiring a walking aid, so typically a walker, and someone who actually is wheelchair bound or has significant swallowing problems. And so there are some patients who, within the first 2 years of diagnosis, feel that they are palliative and they just want to be palliative. And the reality is that we want to use the best resources at the right time for the right person. And what our clinic has targeted, and many clinics have targeted, is people with unaddressed symptoms and people who have couples or families where there is caregiver burnout, and specifically when they have pain as a significant problem. We will address for short-term existential distress, but ongoing needs for psychotherapy are likely not best met in a neuropalliative care setting. So people who have had lifelong depression should continue with their mental health professional in the community. And if they need assistance or input, they can call the psychiatrist attached to the Movement Disorder Center or to a neurologist that they see for advice and tips on things that seem to be helpful. But requiring ongoing neuropalliative care needs is likely not possible. I would say that the number of centers that actually provide true neuropalliative care are very limited. There's probably less than 5 in America that truly provide neuropalliative care. Many people say they do it, but they are not closely linked with a palliative care specialist. And in my experience, I feel that this is essential before you call yourself a neuropalliative care clinic, because the palliative care specialist has a very specific set of skills. They are so skilled at pain treatment, end-of-life care, having difficult conversations, and being able to manage challenging family dynamics. For a neurologist, the neurologist has all this content expertise about what is a movement disorder, how to treat it, how to problem solve around it. But those expertise that the palliative care specialist has really are not part of a typical neurologist toolkit. So either the neuropalliative care program has to be led by a neurologist who has palliative care certification, or a neurologist palliative care physician dyad, so that the team is working together to address patient needs. In my clinic, I have always had a spiritual care provider, and that is because it's not about religion. It's about the questions of, why has this happened to me? How can I be hopeful? And how can I move forward? As well as addressing the care partner or caregiver distress over the change in dynamics, the change in roles, and lessening guilt, which is a significant challenge.
Right. So when people come to your clinic, they have, you know, you're going to see this person, and you have like a plan, and then you have a general follow-up plan that these people are going to see you every few months, couple of months, and they're just being monitored by more people.
So we have a number of different follow-up plans. One is for some patients, they just require one consultation and they are sent back to their neurologist, and we're happy to see them again. For other patients, they are very comfortable with their neurologist or family medicine specialist, and they're happy to continue in that manner and see us as they need. And then for occasional patients who we feel they may require either palliative home care or an inpatient admission to a palliative care service, we will see those patients more frequently.
Okay, great. So I'm going to go through some of these questions. We're getting close to the end, so I just want to make sure that we get through some of these. So somebody asked, is shortness of breath a symptom of Parkinson's and therefore makes exercise more difficult? Is that the case, that shortness of breath is a symptom of Parkinson's?
Shortness of breath can be a symptom of Parkinson's. And once again, I think you have to be checked by your family doctor to make sure that there aren't any cardiac or lung issues that are causing this symptom. If you have been checked, then the probable conclusion is that this is from your Parkinson's. Once again, it tends to be related to wearing off of the medication. And many patients actually experience significant anxiety at the same time that they have this shortness of breath. Again, speaking to that it's a wearing off, non-motor fluctuation symptom. And so trying to keep the person more on, but more importantly, trying to address anxiety. And if there are any cognitive issues, to address those symptoms first to see if that can relieve some of the shortness of breath symptoms.
Great. So somebody was talking about how the spasms in their legs are really, really bad, and they took their medication a long time ago, and now it's so bad, and they're not supposed to take it again for a while, but they're so terrible they can barely move around. So to me, this would seem like a conversation immediately with their doctor to say, can we bump it up, hopefully, so that their meds can, they're not waiting so long in between taking meds, so they can maybe help with this pain. Or as you said, you know, it might be a situation where there are other types of drugs that could be used in conjunction with it.
Yeah, one treatment that I didn't mention that is specific for Parkinson's is botulinum toxin. So botulinum toxin can be very effective if someone is having repeated dystonic pain. And however, people have to recognize that it weakens the muscle. That is its job, is to weaken muscles. And so if you get an injection in your leg, it might get rid of the dystonia, but it might also weaken the muscle so that you notice it when you are doing other activities. But this is probably an underutilized treatment for pain in Parkinson's disease.
So when somebody does come in for an injection, how long will something like that last? If they have, you know, let's say they have chronic dystonia and, well, not chronic, not all the time, but it's a regular occurrence for them and they come in and get an injection. What's the life of that?
So many patients will have onset of benefit within 1 to 2 weeks, and the duration of benefit is approximately 3 months. This means that they have to have the injections done every 3 months. So it's not a one-time deal.
But is it a one-time injection when you start and it can last for 3 months and you come and get another one, or is it like a series of injections that you get?
Generally, people should be injected only every 3 months, because if you inject less frequently, I would say probably every 10 weeks would be the least amount that you can do. But people who get small amounts of injections, multiple every few weeks, are more likely to develop tolerance to the botulinum toxin, because it's as if you're being vaccinated against it.
Okay. Because somebody had asked earlier about lidocaine patches, how are those, do those work well? Have you found in your practice that those work well for people who are experiencing cramps and stuff like that?
I have not actually tried lidocaine patches.
Okay. Okay, sorry, we don't have an answer for that one. Let's see. A couple of people said, you know, they have DBS and they're feeling great, and no problems at this point. And then a couple of people are asking, you know, like, when is a good time to look into DBS for something like this?
Probably before the patient thinks it is.
Right. I think it's so confusing, right? Because they were told, oh, this is the last chance, and now it's definitely not that situation, right? So if you're wondering about,
I'm not sure that I've ever heard this is the last chance, but and then it changes because the criteria for deep brain stimulation is that you have still a very good response to levodopa. Deep brain stimulation does not improve beyond the best response to levodopa. That's the first thing people need to be aware of. And many, even neurologists say, well, then why do it? Well, the reason why is the maximum benefit is no better than the maximum benefit from levodopa. That's why we need patients to respond to it. But the deep brain stimulation means that the off time is less severe and shorter. Also, if you have dyskinesias as a bothersome symptom or painful dystonia that is significant and disabling, those would be other target symptoms. And the time to consider deep brain stimulation is, in fact, when you have those symptoms and you're still functioning okay, but you're noticing it's starting to impair your ability to function, and you are cognitively relatively normal. So the biggest pitfall we find is that patients wait until well into their 70s. And at that time, just in general aging, people are already starting to have memory problems. But then you add on top of that, you have a neurologic progressive condition, then you are more likely to have cognitive problems. And the reason why we don't want to do brain surgery for someone who has cognitive problems is that we know that these patients tend to benefit less from the deep brain stimulation, and they tend to have more cognitive problems after. And so any intervention that we do, we are trying to maximize your benefit and reduce your risk as much as possible. So the commonest line I hear from people who refuse deep brain stimulation is, I'll tell you when I'm ready. And often when the neurologist initiates this conversation, it's because they feel the patient is actually ready to have surgery, has the appropriate target symptoms, and they're concerned that either they're getting to an age where they tolerate the surgery less well, and there is good research to show that people over the age of 70 actually get less benefit and have more risk. And that we're concerned about cognitive status because, particularly for highly educated people, they look great for a long period of time. And then when they start to decline, they can decline very quickly because they have this much reserve and they've gone through it. So they're still behaving normally and talking normally and thinking normally, but they've gone through all this super duper intelligent reserve. They've gone through it, and now they're going to really decline much faster. Whereas someone who has not had the same education opportunities, the same career opportunities, they often tend to decline a little more slowly like this, and we can follow that with general screening tests.
Great, thank you. Well, we are just about out of time. I would love for you to just share maybe 3 actions that people can take every single day to minimize, or in an ideal world, eliminate pain. What are 3 things that you do?
Well, Buddhists would say that living is a painful condition. And so not to make light of that, it is, we're all going to experience pain of some kind in our life. It's how we respond to it and what we can do to mitigate it or reduce it. And so I think some of the things we've talked about is, one, taking your medications regularly. I cannot emphasize enough, we didn't get a chance to talk about this, have a daily bowel movement. Because of course, if you have a daily bowel movement, your medications work better. And if your medications work better, you're more likely to have a smooth response throughout the day. And addressing any mental health issues. So many of our patients experience anxiety and depression and sleep disruption. All of those things will reduce your ability to face pain or face the challenges of having a chronic medical illness. So we want to address those things as well. And finally, to not discount everything to your Parkinson's. So I can't tell you the number of times I've heard the most bizarre symptoms and the poor patient was told, oh, that's from your Parkinson's. No, that is not from your Parkinson's. So to make sure that your primary care physician actually is open enough to think of other diagnoses when you present with pain or discomfort.
Great. Thank you very much. I really appreciate you being here. I know everybody got so much value from listening to you. This is a topic that we hear a lot about, and people have a lot of confusion and frustration around what to do about it. So I hopefully this will give people tools and recommendations to talk to their doctors about, and we'll be able to find some ways to help minimize some of the pain that everyone's feeling. So thank you so much for being here. And to everybody on the call, we will definitely be sending out the link once the recording is ready so that you can listen to this again. And we'll do the show notes so that we will talk about the medications that Dr. Miyazaki shared so that you can check those out and talk to your doctor about them. So thank you very much.
Thank you.
Thanks. Bye, everybody.